Hi, my name is George Castro.
I'm Tanya Gill.
Hello, my name's Atsiri Maldonado.
And I'm All Yang.
This is our case study on respiratory renal failure. A little background is Mark Peterson is a 45-year-old African-American male with a new diagnosis of cardiomyopathy with a 40% ejection fraction. He has poorly controlled type 1 diabetes mellitus, hypertension, and stage 3 chronic kidney disease. He is a one-pack per day smoker who came to the emergency department with increased redness in his lower extremities, fever, and chills. He was diagnosed with cellulitis and acute renal failure. He has received his first dose of ceftriaxone and the ED, and he has a baseline creatinine of 2.8, and his current creatinine is at 3.9. His white blood cell count is at 18.5. His initial set of vital signs included a temperature of 99.8 Fahrenheit, pulse at 84, respiratory rate at 22, BP, blood pressure at 148/88, and an O2 sat at 93% on room air. He is fine by bapsular crackles in both bases posteriorly that do not clear up with a cough. Respirations do not appear to be labored, and he denies shortness of breath. Some of the relevant data is that his cardiomyopathy is 40% ejection fraction with the type 1 diabetes mellitus, hypertension. His new emergency department diagnosis cellulitis and stage 3 chronic kidney disease. The labs related to that are the creatinine at 2.8, baseline. Currently, they're at 3.9, white blood cell count at 18.5, respiratory rates at 22, and O2 sat is at 93% room air. The clinical significance of the cardiomyopathy is that it makes it harder for the heart to pump blood to the body. A 40% ejection fraction can indicate heart failure. A combination of diabetes mellitus and hypertension increases the risk of heart attack, stroke, and decreased kidney function. Hypertension may lead to cardiovascular disease, stroke, and chronic kidney disease. Fever accompanied by chills, localized erythema, warmth, and tenderness in the lower extremities indicate infection. Long-term decreased renal function. It is important to monitor labs such as the BUN, creatinine, and the creatinine clearance. The lab's clinical significance is that high-level creatinine may indicate kidney disease, and elevated white blood cell count can indicate inflammation and or infection. So 4 hours later, Mr. Peterson's O2 sat on room air has decreased from 95% to 88%. His respiratory rate increased from 22 to 28 with coarse crackle lung sounds halfway up bilaterally, and a PRN of oxygen implemented to raise oxygen to 92% or above. His O2 set is at 2 liters, and Mr. Peterson's O2 increased to 94% on those 2 liters. Another 2 hours go by, and his vital signs is that his respiratory rate is now at 24. O2 sat is at 90% on 2 liters. So the nurse then titrates oxygen to 4 liters. The vital signs are then 99.6 temperature Fahrenheit, a pulse at 94, respiratory rate at 28, blood pressure at 156/90, and an O2 as at 92% on 6 liters of oxygen. Mr. Peterson has not voided since admission despite 400 milliliter fluid intake. A bladder ultrasound reveals 90 milliliters of retained urine. Primary care providers notified of Mr. Peterson's increased oxygen needs and subjective report of filling SOV. The clinical significance is tachypneic respirations. The lungs are working harder to compensate, and the body is requiring supplemental oxygen to obtain adequate oxygen perfusion. The crackles now halfway up the lungs indicate fluid filling up the lungs with absent lung sounds at the bases. The elevated BP and hypertension disrupts homeostasis and increases oncotic pressure. The heart and lungs are overstimulated, trying to deliver adequate blood volume to the body. The fluid retention is related to decrease the GFR/kidney disease and increased blood pressure needs of the heart rate due to the ejection fraction at 40%. The management of care. So we would ask the patient for all medications taken at home, prescribed, and over the counter. Review the recent medical treatment. Review and confirm allergies and related outcomes. Subjective assessment of pain, ability to perform daily activities, quality of life expectations. A continuous monitoring of vitals, edema, peripheral tissue perfusion, and cellulitis. The labs we will look at will be the CBC, the BUN, creatinine, urea, calcium, potassium, and serum glucose, and the ABG. The diagnostic test would be the chest X-ray. We'd administer antibiotics as ordered for cellulitis and titrate oxygen as needed to maintain an SpO2 above 92%. We will administer 800 milligrams of acetaminophen with hydrocodone every 6 hours as prescribed for pain, valued at 6 between 10, and a monitor for pyrexia of a temperature above 100.4. The physiological adaptation. Mr. Peterson's new diagnosis of cardiomyopathy with a 40% ejection fraction has caused his heart to compensate by increased oncotic pressure in order to perfuse vital organs. The heart's compensation and poorly managed type 1 diabetes has caused chronic elevated blood pressure, resulting in chronic hypertension. Mr. Peterson's smoking habit has also exacerbated these symptoms. Chronic hypertension and mismanaged type 1 diabetes is a direct contributor to Mr. Peterson's decreased renal function and stage 3 renal failure from long-term overworked kidneys. The reduced renal function is confirmed with the bladder ultrasound finding 90 milliliters of retained urine after 400 milliliter of fluid intake and 0 urine output in the previous 4 hours. The fluid in Mr. Peterson's body is not being properly excreted. Therefore, the excess fluid has found space in his lungs, as is determined by coarse crackles mid-lungs bilaterally. The third spacing of the fluid in the lungs is causing Mr. Peterson's respiration rate, which is currently at 28, to elevate to a state of hyperventilation, resulting in a respiratory alkalosis with his blood pH being at 7.6. Mr. Peterson's condition requires immediate medical intervention. The nursing priority would be the impaired gas exchange. The first intervention will be to have the head of the bed at 30 to 45 degrees decreased to decrease the risk of aspiration and the related complications. Continuous monitoring of respiratory rate. Note the use of accessory muscles and nasal flaring. Monitor the SpO2 continuously using the pulse oximetry. Administer humidified oxygen with a target O2 saturation of 92% or greater. Auscultate the breath sounds every hour. The presence of increased crackles and or wheezes alerts to the airway obstruction, which will exacerbate existing hypoxia. And watch for physiological signs and symptoms of distress, which can be anxiety, agitation, insomnia, and delirium. The rationale behind this is that an elevated head of the bed to a 30-45 degree angle reduces the risk of aspiration and increased thoracic capacity and increased lung expansion. Respiratory rate greater than 30 indicates inadequate oxygen perfusion and leads to respiratory alkalosis with prolonged increased respiratory rate. The pulse oximetry allows for continuous O2 monitoring and alerts to increased O2 needs prior to a state of decreased LOC. Supplemental oxygen should be titrated based on patient's needs. Auscultation of breath sounds is important to monitor for changes to patient's condition, and changes in behavior and mental status are signs of impaired gas exchange and inadequate tissue perfusion. The expected outcomes will be patient will have adequate oxygenation as evidenced by blood gas levels within the normal parameters, which is 7.35 to 7.45. The patient will maintain clear lung fields and remain free of physiological signs of respiratory distress by discharge. The pulse oximetry will retain at 92% or greater for the duration of the inpatient stay. Patient will verbalize understanding the oxygen supplementation needs and other therapeutic interventions. And the patient will inform the nurse of pain, shortness of breath, chest pain, and overall discomfort. There you go.
The nurses have communicated concern of increased oxygen needs and fluid retention using the SBAR method to the primary care provider. Doctor orders a STAT portable chest x-ray, CBC, basic metabolic panel, and arterial blood gas. The patient is assessed for pain using the PQRST method, but the patient denies pain. His current physical assessment is he appears tense and anxious without facial grimacing. His breath sounds are coarse crackles halfway up bilaterally on posterior lung auscultation. Patient is tachypneic with slightly labored respiratory effort. His complexion is flushed, warm and dry without edema. His heart sounds are within normal limits. His pulses are weak, 2+ equal palpation at radial pedal post-tibial landmarks with brisk capillary refill. The patient is awake, alert, and oriented to person, place, and time and situation. His abdomen is flat, soft, non-tender. Bowel sounds are audible in all 4 quadrants. His bladder is not distended, not tender, and the patient is unable to void since admission. He has 90 milliliters of urine retained, determined by bladder ultrasound. He has erythema present bilaterally on lower extremities, feet to mid-calf. The redness has not progressed beyond outline edges. The skin is warm to touch with 2+ non-pitting edema. The clinical significance is inadequate oxygen perfusion, hypoxia, short of breath with oxygen supplementation, pulmonary edema indicating third spacing of fluid in the lungs is likely, no urine excretion with 400 milliliters of fluid intake after 6 hours indicates renal insufficiency and fluid retention. The onset of swelling, localized redness, warmth, and pain accompanied by fever, chills, and sweating is due to cellulitis. His chest x-ray reveals normal cardiac mediastinal silhouette with patchy opacities throughout the lungs. Signs and symptoms related to pulmonary edema, decreased tissue perfusion related to renal disease and hypertension. These are his current lab results. Sodium is 132, potassium 4.8, glucose 345, BUN 71, and creatinine clearance is 4.3. His CBC came back with 18.8 white blood cell count, 8.2 hemoglobin, 305 platelets, 91% neutrophils, and 0 bands. His glucose is very much elevated, indicating hyperglycemia due to uncontrolled type 1 diabetes mellitus. This can cause other complications such as neuropathy, diabetic retinopathy, coma, headache, fatigue, nausea, vomiting, blurred vision, damage to blood vessels, and confusion. His BUN indicates decreased urine output related to renal impairment, causing protein accumulation in the bloodstream. The creatinine clearance is increased with renal dysfunction. The white blood cell count elevated can indicate inflammation or infection. The hemoglobin indicates renal failure, which is linked to decreased production of erythropoietin by the kidneys, and low EPO causes decreased red blood cells and anemia. His neutrophils at 91% are elevated, indicating his body is fighting infection. And arterial blood gas lab results indicate his pH is 7.6, his carbon dioxide is 25, his oxygen is 70, his bicarbonate is 26, and his O2 saturation at 90. The ABG labs are used to identify the specific acid-base distribution and degree of compensation within the body. Results of ABG analysis provide information about alveolar ventilation, oxygenation, and acid-base balance. Our patient is in respiratory distress, as indicated by his respiratory alkalosis. Respiratory alkalosis is a clinical condition in which the arterial pH is greater than 7.45 and the blood PCO2 is less than 35. Respiratory alkalosis is caused by hyperventilation, which causes excessive loss or blowing off of CO2, and hence there is a decrease in the plasma carbonic acid concentration. Priority for Mr. Peterson is to manage his symptoms of chronic disease. The first thing we're going to do is administer a diuretic. Initially, it'll be furosemide and then long-term hydrochlorothiazide. We're going to provide a non-rebreather or administer a high concentration of humidified oxygen. We're going to give an antihypertensive, and we're going to monitor input and output as well as daily weight. And we're going to educate Mr. Peterson on smoking cessation and refer him for palliative care. The diuretics will stimulate the kidney and cause diuresis. Oxygen is needed to stabilize his respiratory rate and O2 perfusion. The antihypertensives, metoprolol and atenolol, are selective beta-1 blockers, which will stimulate the kidney function and cause vasodilation, decreasing hypertension. We are going to monitor his daily weight, vital signs, auscultation of lung sounds, nutritional status, which are all indicative of health status. The smoking cessation will decrease symptoms related to hypertension, such as vasoconstriction, and comfort care is needed due to progression of chronic disease. The diuresis will increase urine output, decrease edema and third spacing. The oxygen will increase oxygen perfusion above 92%, which will stabilize ABGs and respiratory rate. stabilization of blood pressure, decreased renin, and reduced cardiac output via the antihypertensives. In the post-diuresis, patient will maintain normal weight pattern, not exceeding plus or minus 5 pounds per day. By quitting smoking, it reduces symptoms of cardiovascular disease emphasized by smoking. And palliative care will help improve the quality of life for Mr. Peterson and establish comfort goals.